we're going to cover the basic implant placement protocol. We have a patient who is missing number 20, presented with a pan. We can appreciate from this partial pan there is adequate space mesodistally between number 19 and number 21 for a crown to be placed, and we can appreciate that there's no over eruption in the opposing tooth. We can appreciate that the vertical dimension is adequate. We can see the inferior alveolar canal inferior border and superior border here, and we decided to go ahead and take a look at the patient intraorally. Looking at the patient intraorally here, we can, on the left side, we can see the mandibular torus and how prominent it is. However, on the buccal aspect, the buccal bone seems slightly deficient. There's a fixed retainer to preserve the space that was placed by the orthodontist. On the upper right corner, we can appreciate a lingual view here showing the gingival health. On the lower right picture, we can appreciate the adequate zone of keratinized gingiva. It is very helpful to keep the crown margins clean if there is an adequate zone of keratinized gingiva, and we can appreciate the mucogingival line here in this view, separating between the pale pink color from the alveolar mucosa, which is more red in color. On the left-hand side, after the CBCT was manipulated, we used the software to insert the implant of the appropriate diameter and length after we drew the inferior alveolar nerve on the left-hand side here. We went ahead and had the software add an abutment on top of this implant so we can position this implant appropriately in the center of the site to be in occlusion properly and to be in the line that is connecting the central fossae of the molars and premolars. As we can tell from the upper right hand side picture, I placed the abutment right in the center of this line that connects the central fossae of number 18, 19, and 21. On the lower hand view is a very important view. It is the cross-sectional view right in the center of where the implant's going to go. Okay, this cross-sectional view. On the right-hand side, it is the buccal wall, while the lingual wall is on the left, right? We can appreciate the mental foramen exiting the buccal wall. We can determine here in this position that I had used to place the implant. The implant is placed too buccally. It's very close to where the buccal bone is. Okay, it's going to be very difficult not to have a perforation in this buccal wall. Therefore, it was determined that I should move the implant slightly lingually while keeping the exit of the abutment to occlude the opposing arch appropriately. Okay, the cross-sectional view on the lower right is also utilized to measure on the software how much vertical bone we have and how much buccolingual bone we have and where exactly we're going to place the implant. Moving on, we did the clinical exam and fabricated a surgical guide. We utilized, in this case, a vacuum-formed surgical guide with lines to determine where the implant or the drills should go with a hole in it. Optimally, I would have chosen a fully guided surgical guide for dentists who did not place many implants. In this particular case, we went ahead and performed sulcular incisions, reflected the buccal flap, inserted the surgical guide, went ahead and used the initial drill, which is the BTI initiator in this particular case. Accidentally, the hole, since it was too large, the drill was positioned too far mesially rather than centered. Okay, on the right hand side, the photo shows actual proper occlusion. The drill eventually occludes with the opposing arch. If we look closely also, the drill follows the line of the central foci of the molars and the premolars on the bottom. Okay. Moving on, we took a radiograph. In this radiograph, the BTI initiator was inserted only 6 millimeters before I take the first radiograph. I don't want to go ahead and insert my primary instrument all the way to full length, because just in case I need some adjustments to be made to my angulation or positioning, such as here. Okay, we can determine I am pretty centralized between the molar and the premolar. So I am happy with my positioning mesiodistally. I drew, using the software, these red lines vertically from my drill, top to bottom, and the premolar top to bottom, made sure that they're parallel. Okay, and on the apical portion here, I made sure that I'm at least 1.5 millimeters away from natural teeth, so that I don't encroach on the PDL of the neighboring teeth here. Okay. Moving on, I went ahead and inserted the BTI initiator to full length of my planned implant. Okay, and drew the lines vertically to make sure I'm parallel to the premolar. And in this particular case, I found that I had deviated slightly towards the mesial. I would have rather positioned myself a little bit distally to be equidistant between the premolar and the molar. Okay, and these measurements show approximately a 0.6 millimeter deviation here that can be corrected with the following drill, or it can be corrected with a Linderman drill, which is more like a crosscut Fisher burr. Okay, moving on. This is one of the following drills that I utilized, and even though we are parallel to the premolar as the vertical red lines indicate, but I am still more towards the premolar than the molar. I'm not coronally, I am not centralized. The space between the enamel or the contact area of the premolar and my drill is much smaller than the space between the contact area of the molar and my drill. Therefore, I want to tilt the head of my handpiece in my future drills. I want to tilt the head of my handpiece slightly distally. Okay, we went ahead and took a photograph of the following drill. On the left hand side, we can see now that I corrected my position. I am equidistant mesiodistally. On the right hand side, the view shows the drill is equidistant also buccolingually. It follows the line of the imaginary line between the central foci of the molars and the premolar and the canine. It also occludes the opposing arch appropriately. All right. Finally, the implant was placed because we were happy with the positioning. The implant was placed 0.5 millimeter subcrestal in this location. As I said, different dentists prefer different protocols in if it was subcrestal or at the crest level. Some implants actually have a polished collar that needs to be supracrestal. But in any case, the positioning of the implant is adequate. On the right hand side picture, we can appreciate adequate bone dimension between the implant and the buccal plate. We need at least 2 millimeters. Well, if you want to push it, it can be 1.5 millimeters all around the implant for good long-term implant and bone viability. As we can tell also from the right-hand picture here, my crestal incision was not in the midline. It was slightly paracrestal. Again, different practitioners practice different methods. So in this particular case, it was easier for me to do a paracrestal incision so that during my drilling, I do not need to worry about reflecting the lingual flap with my other hand. Only the buccal flap was reflected. Moving on, the final slide here shows the healing abutment in position because I had achieved adequate primary stability. Adequate primary stability over 35 Newton centimeters. Again, different practitioners have different numbers they go by. Again, different implant systems have different numbers. In this particular case, we took a radiograph, and this is a Straumann BLT, bone level taper that is. I can appreciate the centralized location of this implant in this missing site of number 20. We can appreciate the slightly subcrestal positioning of the implant, and the radiograph has a little bit of a vertical tilt, so I know clinically that I'm only half a millimeter, not so much more than that. We don't need so much more than half a millimeter subcrestal in most situations. Okay. The summary of what we discussed: if you're doing your first implants, we have to evaluate the site appropriately, both clinically and radiographically. Radiographically, preferably with a CBCT, not necessarily, but preferable to be able to calculate the bone volume and measure both mesodistal, buccolingual, and apicocoronal bone volume. Okay. Proximity to vital structures need to be taken care of. We need to make sure that we're away from the nerves appropriately, at least 2 millimeters. If we're working on the maxillary arch, the nasal floor and the maxillary sinus floor needs to be taken into consideration as well. Soft tissue should be evaluated clinically. We need to have it's preferable to have keratinized tissue all around the future crown of the implant for good oral care. After evaluating the CBCT and the clinical impression, we go ahead with the digital planning, use our software to place the implant on the CBCT and position it appropriately, preferably fabricate a surgical guide to help in placement and angulation of the implant. This will reduce the surgical time and reduce errors. Pre-operative antibiotics and chlorhexidine rinse are advisable. Incision design need to be taken care of. Some practitioners would prefer a papilla preservation technique. Others do the sulcular technique. It depends on the situation, honestly. Intraoperative radiographs are essential to make sure that we are in the appropriate position mesodistally, and apicocoronally we need to be away from vital structures such as neighboring teeth PTL and nerves or so forth. Monitoring the position is essential in all dimensions, and the angulation as well clinically needs to be evaluated periodically by placing the drill into the osteotomy site, having the patient slightly close until they touch the opposing arch with the drill. Okay, we need to be cognizant that we're not perforating the buccal or the lingual plate if we are drilling. A lot of times we perforate the buccal plate, okay, we can graft, but then perforating the lingual plate on the lower portion here, especially if there is a severe lingual concavity. Okay, in this particular case, in this particular patient, we did not have a steep lingual concavity, which is very fortunate. However, some practitioners, if they perforate the lingual plate, it is a concern because there are vital structures there, such as blood vessels and nerves. We have to follow also the manufacturer's recommendations on drilling speed and sequences of drilling, if it's hard bone or soft bone, that can be determined during the surgery. And after suturing, we have to determine that we have as closed of a wound as possible to minimize the chances of post-op infections. I hope this helps. Thank you very much.